Thank you. Thanks, Anat. Thanks, everyone, for coming and inviting me to talk today. So I'm going to talk about cataract plus glaucoma because sometimes I think it can be difficult to sort out what to do in some of these cases. Okay. So I think a lot of times when we talk about cataract surgery in general, and especially cataract surgery in our glaucoma patients, it can feel a little bit like an alphabet soup of different options, different types of IOLs, different types of glaucoma, different types of adjunct procedures that we can do for our glaucoma patients. So I've broken down the talk into two sort of basic sections, which I'm going to call simple surgery in complex patients and complex surgery in simple patients. By simple, I mean standard phaco. So I'm going to start with pseudoexfoliation. I think it's hard to talk about cataract surgery and glaucoma without talking about pseudoexfoliation, which can really cause us a lot of problems. I'm going to show just a short video, and if you focus your attention on this part of the video, I think you can see a significant amount of zonular dehiscence and phacodenesis in this cataract patient who ended up having actually more than 180 degrees of dehiscence. There's a lot of ways that we can deal with this kind of a situation. This particular case, we went with a standard anterior chamber lens. I think a little bit later we're going to see some other ways to deal with lack of capsular bag support for IOLs. This is a different patient who had a sulcus place lens, who had much less area of zonular dehiscence, but even in this case you can see that there's a lot of capsular phimosis behind the sulcus IOL. I think we can really achieve very good outcomes in our pseudoexfoliation patients if we follow some basic premises to prepare our patients ahead of time that they might not have a 5-minute cataract surgery. And I really like to consider blocking these patients. I think it's very difficult to deal with both a moving patient who might be in pain and also trying to deal with doing some sort of a secondary IOL at the same time. Also tend to veer on the side of caution in terms of using capsular expanding device, iris expanding devices, and capsular staining in these cases. And it's stuck again. Sorry. I think it will, if you can advance it, I don't know. Yeah, it's not advancing. Can you advance the slide? There we go. So this is some other instances in which glaucoma can cause us issues with our cataract surgery. Previous trabeculectomy surgery can be a problem, mostly in terms of really wanting to limit inflammation. If you can keep advancing, that would be great. Previous tube surgeries also can cause us troubles in terms of the length of the tube. If the tube is too long, that can be a problem. We tend to have issues with low intraocular pressures in these patients with previous tubes. And again, if you can advance. Great. There's just going to be a short video here of somebody who had a previous aqueous humor shunt or tube in the supratemporal quadrant. And a couple things just to notice here is that I'm constantly, during the case, fighting with the globe wanting to rotate inferiorly. I have to keep holding with my second instrument throughout the case. And then the other thing you can see is the striae in the cornea because the pressure really stays low throughout the whole case. And again, at the end of the case, very low pressure, and I find almost always I have to suture these wounds closed because you really just can't get the pressure high enough in the eye to keep your wound closed. So we're going to switch a little bit and talk about what I'm going to call high-tech cataract surgery or toric and multifocal IOLs in our glaucoma patients. And the thing that makes this challenging in glaucoma patients is we have to try to predict what's going to happen in the future with our glaucoma patients, which is very difficult. So certainly in patients with pseudoexfoliation or any reason that they might have zonular dehiscence, toric and multifocal IOLs can be a particular concern because as they decenter, they're going to have even more effects on our patients. And again, if you can advance for me one more time. I'm just going to hopefully start a short video with a toric IOL. Thank you. So Toric IOLs I think are extremely good and helpful in a large group of patients, even those with glaucoma. But something to keep in mind is that patients that have had glaucoma surgery or may have glaucoma surgery in the future may be prone to having irregular astigmatism. If you can advance again. If you can just advance to the next slide. Past the video. There we go. So this is a topography of a patient that has an aqueous humor shunt, a tube in the right eye, and you can see how irregular the astigmatism is, and the left eye does not. And again, advance. Let me advance to the next slide. Again. And then this is a topography of a patient with a previous trabeculectomy surgery. And I think you can see that there's a lot of steepening in the superior half of the cornea there. And so these are some cases where we might want to reconsider our choice for a toric IOL. Can we advance again? So let's talk about multifocal IOLs in glaucoma patients. And there's a lot of debate over whether or not these are good for our glaucoma patients. I think we could probably agree that in very advanced glaucoma, it's not a good idea, mostly because of, we know that there's some decrease in contrast sensitivity. And there's been a few studies that show patients have a decrease in their mean deviation on their Humphrey visual fields after multifocal IOLs. Can we advance again? I'm going to just show you a short case of a 65-year-old man that came into our office that had glaucoma but was taking only 2 drops. And advance again. Again. And has a fairly normal visual field. The right eye completely normal. The left eye has an early nasal step. Advance again. His OCT, retinal nerve fiber layer analysis, is really totally normal on the right and has some significant thinning on the left. Advance. So he had the multifocal in his right eye and was very happy, and now it comes to what to do with his other eye. Can we advance again? And again. Again. So he's taking, so I'll back up a little bit. So he ended up not immediately having his left eye. Some personal things interfered with his surgery getting scheduled for the other eye, and he actually didn't come back until another 5 years later. At this point, he's taking 4 topical medications. Advance. And has very uncontrolled pressures, even on the 4 medications. Advance. And now worsening of his cataract in the left eye, so he really wants something done with the cataract at this point. Advance again. And advance again. So this was his previous visual field, and advance one more time. And now his visual field has progressed, actually, in his left eye to having a double arcuate defect. And advance again. So now we're left with this patient that has a multifocal in one eye and now has uncontrolled glaucoma and a cataract in his other eye. And advance a couple times, one more time. And so we have to decide, are we going to put a multifocal in this patient or not? Go ahead and advance a couple more times. And so I decided not to do that. I went with the standard IOL with the trabeculectomy because his pressure was really uncontrolled on maximum medical therapy at this point. He ended up quite happy, had a pressure of 8 without any medications and reasonably good vision in the left eye. And you can keep advancing, yeah. I'm going to skip over this slide a little bit so I have time to show the last video. You can advance a couple more times. And again, I'm going to spend the last 50 seconds talking about what we've termed in the US now minimally invasive glaucoma surgery, or MIGS. I don't know if that translates to Spanish at all. And we can advance a couple more times. Great. So there are several of these minimally invasive glaucoma surgeries. One is an eye stent, which is recently, I guess not so recently anymore, FDA approved in the United States. Endocyclophotocoagulation, trabectome, and canaloplasty. You can advance two more times. That's the trabectome, that's canaloplasty. And one more time. I'm going to spend my last 20 seconds showing this video, if it will start, of an eye stent procedure, which is something that can be done after a standard phacoemulsification procedure. You just place a gonio prism. You have to have a good view of the anterior chamber angle. And you can use this inserter to place this very small stent. And here you'll see I release the stent. I sort of tap it into place. And you'll see in a second a little bit of heme reflux, which is normal and actually indicates that it's probably well placed. And then you finish your cataract procedure. And can advance again. Advance to the next slide. So the thing to remember about MIGS is that they're really appropriate for mild to moderate glaucoma, and we can probably only expect a modest amount of IOP lowering in comparison with our standard glaucoma procedures. But they can be done, and actually are indicated to be done with cataract surgery in advance. So in summary, just a complex set of options available to us. We have to consider each patient separately in advance. And one last time, I want to just give a special thanks, advance one more time, to my family. One more time, thank you.
That was